Hi, I'm Danielle Dick. I'm the director of the Rutgers Addiction Research Center, and it is my pleasure to be here today with Keith Murphy, who is the director of the Alcohol and Other Drug Assistance Program, which is part of the Counseling Center here at New Brunswick. So thank you so much. Keith has been an amazing partner in working with us as we've launched the RARC. So tell everyone a little bit more about what you do.
Well, thank you for this opportunity, Danielle, and being so kind and so gracious as to have me. And again, I'm just really deeply appreciative of the work that you're doing and the research around addiction, especially here on the Rutgers campus. So essentially, what I do is that, in a nutshell, is that I help students resolve issues related to their substance use. And in doing that work, my job is also to help inform, educate, community members, staff, and other faculty, and other stakeholders on the impact of current using trends on campus, and also to make sure that folks are well equipped to talk to students about substance use issues, and also understand the impact of substance use on the campus as a whole and in the larger Rutgers community, because we do occupy quite a bit of space in New Brunswick, and we do have a really big footprint here in Middlesex County and also in the central part of New Jersey. So it's a big order, it's a big task in terms of helping students see and understand, like, hey, this is where the substance use can take them and the changes that they can make, while also informing and helping staff guide our students in the way towards health and well-being. So long story short.
So that obviously covers a huge amount of things. And as you've said, substance use is something that deeply affects college campuses at the level of the students, staff, our communities, et cetera. So maybe we could dig in, and can you talk a little bit more about some of the specific programs that you do, maybe starting first with students?
Okay, well, first I'll say here at the Counseling Center, we are a small staff who serves a really big community here on campus. And essentially what we do is level 1 ASAM work, which is outpatient care for students. And essentially the idea of ADAP, the Alcohol and Other Drug Assistance Program, was born out of the idea similarly to an employee assistance program, where we keep low-risk students here at the Counseling Center, work with them through their substance use issues. The higher-risk students that push into more moderate and severe substance use disorders, we try and refer out as best we can. We offer some groups, we offer individual care, and then on the other end of the continuum, we offer recovery supports for students. We also help train staff in terms of doing some SBIRC, some brief screening, referral interventions to treatment work, also informing the other staff on how to do some MI, some motivational interviewing, to get folks along and moving along and understanding their stages of change with care. But that's essentially what we do. Students come in weekly for the work that we do here, and they also need very little or no medical monitoring, because if they do make changes with their substance use, there's a danger or threat of them going into like a withdrawal, and we're not equipped to deal with that. So any situation like that, we're always assessing, we're always monitoring, but with the idea of we deal with low-risk students here and their substance use.
So how do students end up working with you in the alcohol and other drug program? Meaning, do you go out and do programs with students or at orientation or things like that to raise awareness about the kinds of services you have, and broadly, what are harm reduction techniques, how to understand substance use, what's risky use, et cetera? Or do students come in to your doors and that's how they find out about it? What are kind of some of the ways that you interact with students?
So that's a great question. So let me go back to the other part of your question in terms of doing interventions with students, and maybe we can kind of expand from there. So health outreach and promotions, they do a lot of the work in terms of intervening with students in terms of initial sanctions, let's say in the residence hall. If a student is found with cannabis or alcohol or bottles or paraphernalia, like first offense or first violation that happens, they go to HOPE. And what HOPE does is that they do basics and K6. They do a screening, they assess, they give students feedback, and the student then, says, oh, thank you for, hopefully, this is what they say, hopefully, thank you for the intervention or for talking to me and helping me understand the impact of my substance use. and then the student will then be on their merry way. We understand that most students here on campus don't end up having or pushing into more moderate or severe substance use disorders. Most times the low-level interventions work to help students make changes as they need to make changes. So what we do is that students come in, they're referred to us by the Office of Student Conduct, they're often referred to us by Health Outreach and Promotions. They're also referred to us by Res Life, as we do mandated interviews for students in terms of like assessing whether or not and giving our input as to whether or not a student is safe to be back on campus, not because there's the part of the university, but also is this the best environment for the care that they need at this point in time. So they come in that way through many different doors, and it could also be a share concern through other staff or faculty or even their own friends. That's the other part of it. The other thing that we do, so it's a both and, we do outreach. We do tabling events. We do offer groups, and we also offer a thing called Open Recovery, which is a peer-led recovery group that's supported by ADAP in terms of being able to provide material support. It's held at the Center for Social Justice Education on Bartlett Street, but that's something that I believe in peer-to-peer work. But we do outreach work, because more often than not, if students don't know about the services, they're not going to come in. And also with the stigma associated around substance use, they'll use in silence and suffer as opposed to knowing that what's available for them. And we know that substance use, left unchecked, obviously with stigma, can be a killer. And we don't want that to happen. We really want students not only just to survive, but really to thrive in this atmosphere, understanding that college has a whole world of pressure. So to answer your question, we do both. And we try to really maintain a presence on campus as best we can, understanding one, stigma, two, recognizing that post-COVID, we're in a totally different world in terms of trying to engage students. So it's a lot of moving parts for a really small staff in terms of like really engaging everybody on campus as it relates to substance use.
So I know that one of the other amazing programs that you're involved in is the Collegiate Recovery Program, and
Yes.
that Rutgers actually has a long history in the sense of being one of the first, or maybe even the first program in the country. And so I wondered if you could talk a little bit more about that program here.
Oh, thanks. So we were one of the first. Actually, the first technical collegiate recovery program was in Brown in 1977. 1983, we started before collegiate recovery had a name, before it was a thing. It was started, and I always go with students first, with 4 other students and Lisa Lateman, who had a wonderful idea to provide housing and support for students who have embraced abstinence-based recovery on this campus with housing. And that was a long process to get it up and going, and we were established in 1988. So the way I look at it is it's kind of revolutionary. And I always give Lisa and actually Brian Kay and Barbara Cash a lot of credit in being revolutionary in what they've done, is that they were forward thinking and providing supports for students that were in recovery. More often than not, the medical model is that most people are coming in with some type of deficit. There's some type of symptomology, something that we have to address. The idea that now folks are in recovery, how do we support those folks? Technically, when they're in remission, technically they don't meet criteria for needing any ongoing support. So that idea, that model of like, hey, coming to the counseling center, providing housing for students who want to be abstinent in a really recovery hostile environment is really dynamic. So here at Rutgers, we have the privilege of having, like you said, one of the first recovery houses, and then also using that recovery house as a platform to fight stigma. Also to understand the problem and the pervasiveness of severe substance use disorders, not only with young folks here on the college campus, but in the larger community as a whole. So for me, it's a real privilege to be a part of that work, knowing that like it started what seemed like a long time ago, but it really isn't a long time ago, about 40 years ago, that students can have a space, students who've embraced the recovery lifestyle can have a space where they feel safe and they feel heard and appreciated, and they can have a really rich and thriving academic career on a college campus, because that was not the norm for a long, long time.
Well, and you mentioned how revolutionary this was, and I think it's worth pointing out again too that this is really something that now research has demonstrated, that it's not just about getting someone into treatment, that one of the big, factors that predicts whether they will successfully stay in remission is whether there's ongoing support. It isn't the idea of, let's patch someone up. Okay, great. They no longer meet criteria for a substance use disorder. Let's, set them back free in the wild. Well, we know that oftentimes environment contributes to substance use alongside things like genetics,
Yeah.
I study. And when you return to an environment where you're around peers who are using, friends who might be, encouraging you to come out with them to places where there are, substances being used, that can be really hard to maintain recovery and to stay in remission. And you talked about college as a recovery hostile environment. And so just to, for those who don't maybe work in the space, think about what that means. If you're choosing to not use drugs or alcohol, and or because you're in recovery and have had a problem with it, we know that there's a lot of risky substance use that happens on college campuses, and that many of the social activities traditionally revolved around places where there's was substance use, at bars, at parties, etc. And so, you want people to be able to pursue their education, be successful. Clearly, that's very important, but to do it in a place where you are not surrounded constantly by temptation, and or you might have the supports to be successful in that environment. That's really what these collegiate recovery programs, recognized decades ago, and that are now springing up at colleges around the country, and also more broadly, just in terms of thinking about recovery, regardless of where one is going back to.
That's correct. Recovery in the community. Having peer recovery specialists is a new thing, and it's a new way of looking at ongoing healthcare, ongoing treatment, and expanding what we're able to do. And the phrase that I like to use is not necessarily a continuum, but a compendium, meaning things that people can pull from in terms of that can support their recovery and their life beyond. So I always think of also Sams's idea of home, health, purpose, and community, and how collegiate recovery fits really nicely into their principles of what it means to have a sustained and enhanced recovery. So those things are absolutely important. The other thing, and I'll say this too, is that for students that have embraced abstinence-based recovery, I say for a majority of them, it's not just a matter of even the temptation, but it's also the fact that this is life or death for them, because they understand the progression. They understand that maybe there are other co-occurring mental health issues that may become aggravated with their substance use. So they have to be mindful, not that they need to be bubble wrapped, but they need to be in a space whereas they feel seen, understood, and that they can go home without the threat of wondering whether or not I can go home or I can go to sleep, without the idea of the noise and all the chaos that's associated with substance use. And then also understanding that, hey, my going to school is also a protective factor for me, but it's also a healing opportunity for my brain and also for my family. So it's a lot of stuff that's baked into something that's a really simple concept, where people can really grow and thrive and really develop a whole new identity that springs out of their recovery. And a lot of that can start here on a college campus, going back to the original purpose of what it means to be on a college campus, which is to grow and develop and be a really wonderful member of society, and whatever that can look like for that individual.
Absolutely. And I started off by talking about what a wonderful partner you have been, and what a joy it's been to get to know you better. I'd, of course, met you when I was at VCU doing similar work, though now obviously we have the chance to do it on a whole other scale here at Rutgers. And so I'd love for you to talk a little bit about what opportunities you see for partnerships between the kinds of programs that you're leading and the researchers that are at the RARC.
Well, thank you for that, Danielle. And one of the things that I've been really want to do is connect one side of the river with the other side of the river in terms of understanding Rutgers University. And oftentimes what happens on the back end in terms of doing research doesn't really trickle into the student affairs side. And also, and with that in mind, I tend to think that the work that we do here on campus with the students, especially understanding their substance use, we're kind of doing stuff that's an echo in time. It's like, it's not necessarily cutting edge, it's kind of current. And I'm like, wow, we've got a major opportunity here with a major researcher like you, who's bringing in so many vast researchers, great minds who are really thinking about recovery science, addiction science, how can we change and improve the lives of the folks that we work with in real time? How can we actually do Rutgers-focused studies, right, where we get great output and outcomes, and we're asking the right questions so that, one, we can think about funding, we can think about campaigns, we can actually be really innovative in the work that we're doing in helping emerging adults understand the impact of their substance use. I can't help but to think that, one, especially the state schools, have a real moral and ethical obligation to make sure that we stay cutting edge and that we're doing the best we can, not only for our students, but also for the taxpayers in the state, and also for the town and community in which they sit. So I see so many opportunities for us to look at the work that we're doing and maybe work smarter as opposed to harder. We've been doing things as we've been doing them for a long, long time. And I'm like, why? I always ask the question, well, why do we have to do it this way? Is there science that backs this up, or is this just really good opinion? And lots of times we do things based on our opinions that really don't really line up to what the science and where the science is actually leading us. So I'm just super thrilled to have you here and just being so open-minded to being able to do so much of the work. And I'll say this, and I'll really be quiet. Again, I'll shout out Lisa Laitman in terms of in her early part of her career and connecting to what it was called the Center of Alcohol Studies, to other researchers to improve measurements and assessments for students. And I'm like, wow, we kind of let that tradition go. I'm like, now we've got an opportunity to do some new things. So thank you.
Absolutely. So that's, all the researchers out there hearing this, because having people who are doing the really hard work like you are on the ground, that are excited and open to, let's, see if what we're doing is effective. I remember Linda Hancock, who I know, who used to be involved in leading our counseling center wellness work at VCU, where I was previously, used to say, I really want to know, am I effective or just busy? Because you all are doing so much amazing work. And so to have partners who are so busy, are so overextended, are doing such important work, who actually are willing and want to make the bandwidth to work with and partner with researchers to say, hey, let's figure out how we can do it better, how we can do innovative things, how we can really be best practices for cutting edge, how are we serving our students? And I think is an exciting opportunity for everyone that's out there. So I like to ask everyone, not just about, what they're currently doing, but how they got here. And I say this in the sense that talking to college students, often they will say, I can't wait to find my passion, or I need to figure out what I'm destined to do. Or even early career researchers or whatnot who say I need to get from here to there and figure out how I get there. And I found that, sometimes the path can be very winding. And so if you're willing, I'd love to hear more about your path to how you ended up here as the director for alcohol and other drug studies at Rutgers.
So I went to Rutgers as an undergrad student way back when. I will say it was like 1990 something. And I had a substance use issue. Did it push into moderate or severe? No, it's probably more mild, but it was growing, it was burgeoning. And what had happened to me was that my first year at Rutgers, I got in trouble for smoking cannabis on the floor in the dorm. And what was offered to me was punishment. The hall director said, and that was probably the policy back then too, and I don't remember because it was all a blur. The hall director there said, we're going to call the police. You can't live in the dorms anymore. There was no due process. There was nothing. I just had to go find out and figure out housing for the next year. And thank goodness it happened at the end of the spring semester. So I had a whole summer to figure out where I was going to go. And thank goodness people down the hall, they were like, hey, we're getting an off-campus place. You can live with us. And that worked out. And that was great. But flash forward, so I also identify as a person in long-term recovery. So I was able to finish college. Nevertheless, my substance use had progressed, and it slowly progressed to such a place where I ended up going into treatment. And where I ended up into treatment, some things happened where I was able to stay on in their internship program and then get my master's degree in counseling, because I knew there was something that I always wanted to do with my life. And because I had a drug arrest, I couldn't teach. I couldn't do that, go that route. And I thought about that. So I got my master's in counseling. I was doing work for about 14 years at this place where I'd gone through treatment, doing essentially almost what I'm doing now. Became a licensed professional counselor, licensed clinical alcohol and drug counselor. Almost 9 years ago, I just looked online, just like I saw this position at Rutgers for a recovery counselor. I was like, wow, that's really interesting. That looks a lot like what I kind of do now. And just for giggles, I put in my resume and a cover letter and just applied. I applied, got the position. Never expected to be here at any point in my life. So it's been nice to come back to Rutgers, and also to understand for a lot of students what it means to deal with stigma, what it means to deal with a system that doesn't quite understand substance use, what it means for a student not to get the help and an intervention that they need. The other part for me as a Black person is understanding what substance use looks like in the Black community, what that means to be having a multiple marginalized identities. What does that mean for me to walk into a pretty white institution and seek help from other clinicians? Am I going to get supported or feel seen or heard? So my work encompasses a lot of stuff, and it's really anchored in one, harm reduction and social justice, because honestly, it's reducing harms that are related to substance use, but also understanding that most people don't develop severe substance use disorders, meeting people where they're at and helping them understand who they are. So for me to be able to come back, work with students in recovery, it was a little bit of redemption, and I'm very glad that it happened here at Rutgers, my alma mater. I never in a million years expected to be here, to have conversations with folks like you, to be here, to be at the counseling center, because when I was an undergrad, I didn't know this place existed. And I could tell you more about all the weird life-changing coincidences that happened as a result of that incident sometime in, 1992, May 1992. But that's what brought me here, long story short. So this work is, as they say, it's me search too, as well as a passion and just a life interest. And I just know what it's like to be in that space. And I want to use the privilege that I have to make sure nobody has to feel a little bit of what I felt before.
I have to say, I never realized that you were a Rutgers undergrad. I didn't know that full arc. What an amazing story. And what an amazing opportunity for you to be able to make a difference, because I love how you raised the fact that, when you were in college, and I hate to say it, but I think this probably still exists at places, both at universities, and we certainly know at workplaces, et cetera, where individuals who might have a substance use disorder and come forward to either get help or get caught as a result of something that's happened from their substance use disorder, and end up getting punishment rather than medical help and essentially assistance in getting into treatment and to dealing with and really helping treat their problems. And so I think that's kept so many people from seeking the help that they need and deserve because of this stigma issue that I know you're passionate about. And so do you want to talk a little bit more about this? How do we change from a punishment model and to a view of recognizing that people have a substance use disorder, that they need treatment, that they need help, that they need maybe information about harm reduction, et cetera? I know this is something that, some places are more advanced at than others. What are your thoughts about this?
So, wow, it's a really big thing. Well, one of the things that we know in terms of how substances were scheduled in the Nixon administration had actually Nixon, long story short, didn't take any recommendations from any clinicians or any people in the field. He just made it a criminal justice criminal legal issue in terms of scheduling. So part of it is, for me, is having science take the lead. And I'm going to say some things. One, the cannabis policy in New Jersey is just ridiculous. It's all over the place, whereas policy went in front of science and not being mindful of like the impact that it could have, especially in Black and brown communities where dispensaries are set up, who gets incentivized in terms of having dispensaries, and where that money actually goes and where that money actually comes from. And that's a whole other ball of wax. So for me, I'm for decriminalization of substances. I think we need to have a space where people can honestly talk about their use and feel like if they do run into issues, they can go and run for help, as opposed to being arrested or incarcerated, because obviously we know that incarceration doesn't work. We're seeing sky high overdose deaths through a terrible supply of fentanyl. And just within the past couple of years or so, the state of New Jersey decriminalized fentanyl test strips. Naloxone is readily available. So for me, I don't know how old you are, but I'll go this way. There was a time when HIV was like a really big public health crisis, and there was a really big push for us to have conversations about safer sex, about what it meant to like needle exchanges. All of those things happened. And I think we're at that place where we need to have a better conversation about substance use in the same way that we talked about HIV and AIDS. And also dealing with the stigma and being more out and allowing people to have these conversations, and moving away from punishing people and creating more opportunities for them to seek help. So, I mean, I could go on. It's a really, really big thing that people don't really, it's such a huge topic because people don't realize, with respect to even harm reduction is based on evidence and science. It's not based on a feeling. Like needle exchanges work, dealing with safe supply, arming people with evidence and knowledge helps them to make better choices, live longer, and then they make changes ultimately on their own if supported. Stigma literally kills people. It literally it increases the opportunities for death with respect to overdose, people using alone, and keeping their current using patterns in the dark. And that's not where we need to be. I could go on and hopefully it's something coherent, but like it brings up so much passion for me. It's hard to pin me down on one thing.
Well, and I think this is one of the ways that here at Rutgers that we can lead the way, is in helping get information out about substance use disorders, about the research on what causes them, how we can effectively prevent them, how we can effectively treat them, support individuals in recovery. And so obviously that's one of the reasons that we wanted to start having these conversations and get this out is, I do hope that with all of us spreading the word and trying to reach out to our communities, I see positive change. We clearly have a long way to go, but I hope that we can all accelerate that process. You mentioned the cannabis piece. I know that many of us who do research in this space, obviously a lot of my work is with adolescents and young adults, and we are very concerned about how policy is happening faster than the research and what the implications of that will be for health. So I think that's something we can dive into another day, really in depth, is thinking about cannabis policy, how it's going to affect health outcomes here in New Jersey, how parents, families, et cetera, can be thinking about making smart choices in this changing landscape.
Yep. Oh, I could say yes.
I would love to also follow up on something else that you mentioned earlier that I've also heard you talk about before as well when giving a talk at a town hall, which is this issue of communities of color, how they've been affected by substance use, by legal policies. I know you do a lot of work in social justice, about looking at who gets into treatment, what even our recovery communities and spaces look like. Are they welcome and open to all? Could you talk to folks a little bit more about some of your work in that space as well?
Oh, wow. So one of the things that I ran into a great deal as a person in recovery was that I noticed that in a lot of treatment spaces and in a lot of recovery spaces, there was a sharp contrast between the quality and care of what a lot of white folks got and what a lot of other folks of color, more marginalized folks got, if they got treatment at all. And we can go back and point to data that we know that that Black men, I think between the ages of like 17 and 30 or something like that, 19 and 30, may meet criteria for a substance use disorder as it relates to cannabis, and know that they need treatment, but will refuse to go to treatment. And that also brings to mind to me, like, one, how much cultural humility, how culturally responsive treatment is, how much is it tailored to someone's own understanding of who they are, where they would like to be, and is it accessible for folks? So not only accessible, is it reliable and dependable? Oftentimes what happens in a lot of treatment settings is that the individual gets dinged for a poor treatment outcome, rather than the institution looking at its own practices and policies and understanding how they supported this individual from the front door to the back door. Like, was there something that we did, rather than, oh, they didn't comply or they couldn't adhere to treatment? Well, what was it about your treatment that was necessarily geared or designed for this individual? So those are things that I actively look for in terms of folks, especially treatment places developing policies. I will actually ask them about, do you have policies set up for folks who feel as though they've been microaggressed, meaning like they've experienced a slight, whether intentional, unintentional, or ongoing slights between staff or other clients in that setting? Do you have a place for them where they can feel heard? Do you do gender affirming care? Not just are you LGBTQIA friendly, but do you offer gender affirming care? If I was a single mother, for example, do you offer, or a single parent, do you offer childcare? Like, how can I get the treatment? Do you offer transportation? Are the hours that you offer treatment, are they workable with me and maybe my work schedule, or all the other things obligations that I have? So those are things that seem little, but they're really big to allow people to engage in treatment. And truth be told, a lot of people have access to treatment, and sadly it's through arrest or through incarceration, but that doesn't mean that they're going to get reliable, dependable help and care. The other piece, and I'll be quiet, and thank you for the wonderful question, is increasing recovery supports after someone leaves the facility, after leaving treatment, making sure that those folks during the recovery support, one, are compensated for their work, they're valued in the work that they do, and there's no role drift, meaning that there's fidelity to the work that they're doing, and it's valued in that they're supporting folks in their recovery. They're not doing clinical work, they're not case management, they are there to help that person where they are to move along in their own personal journey. So those are things that I think about. Those things are absolutely and positively important. And also go on about credentialing for folks who are peer specialists. What does that mean? Do we look at larger healthcare systems and how they may be taking away from smaller folks in the community that could be doing better outreach? So it's a really big thing when we talk about the idea of social justice and equity in these spaces. And we also tie it to access. We also tie it to belonging, and not just diversity in terms of representation, but how do we make sure that we're doing what we're supposed to do in order for people to feel like, if I walk through that door, I know that I belong and I'll get care that's really attuned to my personal needs.
As a basic researcher, when I first started learning about what was going on in the treatment space, I was shocked to learn how little there is from treatment centers about the effectiveness of their treatment, that there is often very little accountability by many treatment centers, or they don't make any information available about how successful their treatment is. And which, if you think about, and when I talk to families all the time, this is one of their huge frustration points, is they'll say, well, I'll ask these treatment centers in the same way that I would when I'm going in to see any doctor, what's the likelihood of success here? Or what if I do this course of action versus that? And you raised that really important point, which is that oftentimes if the individual is not, is not able to maintain remission from a substance use disorder, is not able to move into recovery and maintain recovery, that they are blamed rather than maybe we should think about the treatment center. The treatment centers will say, oh, well, we can't provide this information because, we're dealing with a really hard population and many of them are going to relapse and, that's not the way that we think about treatment in most areas of medicine. And clearly there are a lot of great treatment centers and that is changing. And, now there is information about what are best practices, what is effective, and there are good treatment centers that are providing those services and that information. But I was really shocked that that was not required and the norm everywhere.
Yeah, no, there, like you said, there's very little accountability, and for a time there's so much money being flooded into treatment. It was the wild, wild west. It was like body brokering. It was just the scams and stuff for taking advantage of vulnerable folks, even folks who have resources, vulnerable. Putting up mortgages. Like really paying for loved ones' treatment with their college tuition, all their savings is not unheard of, and just no return and so little accountability. I'm like, how is this possible? And we could, then the managed care, like this 28 days, like where are we getting these numbers? Like, again, research, or is it the dollars that drive the outcomes? And like, that's not the way to do things.
So is there anything that we haven't talked about already that you want folks out there to know? And in particular, if researchers are listening to this, what do you want researchers out there to know about the work that you're doing, the landscape here at Rutgers, or other things related to prevention, intervention, treatment that many basic scientists might not be aware of?
What I really would like, and there's been a movement towards it, is again more recovery-based science, more evidence that points to, that either refutes or confirms that what we're doing in terms of peer work works. And I'm happy to get information that says it doesn't work, and that means we could change the model. And I think I just got an article a couple days ago about how mental health first aid really isn't so effective, and I was like, oh, that's good to know. To me, stuff like that is helpful because then we can do change and then we can be a little bit more innovative. So I need recovery science. And then my second thing is, whatever comes out of most studies, make it digestible and understandable, please. And I know that's a big part of your work, so that folks that don't have PhDs or even master's degrees, or whose field of expertise is not necessarily research, because you speak a whole different language, that they can understand it and then maybe implement things based on the research and the data there. Because it's hard, it's a lot, especially for folks who are just doing this day to day. Oftentimes we just don't get the latest and greatest, and we're just doing what we've been told, maybe literally like 30 years ago, that may not be really relevant. So that's me.
Well, research can be hard to understand even when you're in a slightly different area of research. It's amazing how we come up with our own jargon. It's true in the treatment space too, but in the research space as well. And so I'm going to use this to plug that we also are launching new information about science communication on the RARC website. And we're going to be having workshops, and we've got a work group to really help scientists do exactly that. How do you better communicate your science, not just to other scientists, but to the public, to communities, to providers and clinical individuals who are doing clinical work, so that we can start to, as you say, get those sides of the river talking to one another and working together. So thank you so much, Keith. It has been wonderful to get to have this conversation with you. Thank you for being an amazing partner and all of the great work that you lead here at Rutgers. And we look forward to continuing to find ways to work together.
Oh, same, Danielle. Thank you for being so awesome. You're the best. I appreciate this a lot.